Ladies and gentlemen, esteemed guests and participants, welcome to our webinar powered by Progenix Laboratories Private Limited. Today, we are thrilled to bring together experts in the field of oncology and genetics to explore the latest advancements in the detection, treatment, and management of colon cancer. Colon cancer remains a major health challenge worldwide, and understanding its complexities is crucial for improving patient outcomes. This webinar aims to deepen our knowledge, share insights, and foster a collaborative approach to cancer care. We are honored to have two distinguished speakers with us today. First, we have Dr. Rajendra, a renowned surgical oncologist who will provide a comprehensive overview of early detection and treatment options for colon cancer. Next, Dr. Aruna Priya, a senior genomic scientist and a certified genetic counselor, will share her insights on the genetic perspective of colon cancer, focusing on preventive testing, genetic risk factors, and the role of personalized medicine in cancer management. Thank you, ma'am and sir, for accepting our invitation. Let's begin our webinar with our speaker, Dr. Aruna Priya, holds a PhD in human genetics from Osmania University and is a certified genetic counselor accredited by the Board of Genetic Counseling India. With over 10 years of experience in human medical genetics, her expertise spans dysmorphism, cancer genetics, and both premarital and prenatal counseling. She has made significant contributions to the fields of diagnostics, research, and genetic counseling and has published extensively across various clinical specialties. Without further ado, let's begin our webinar with our presenter, Dr. Anpriya. Ma'am, please go ahead.
Thanks for that kind introduction, Anusha. Good afternoon, everyone. The topic of my today's presentation is genetics of colon cancer. To begin with, cancer at the molecular level is considered as a disease caused by the changes that occur at the gene level, which would eventually alter the way the cell functions, grows and divides. So these molecular alterations at the genic level are called mutations or variations, which instructs the cells to misbehave and lose their natural function. These variations or mutations may occur in any type of cells, including somatic cells and also the germ cells. These variations, when occur in a specialized type of cells called proto-oncogenes, whose primary function is controlled cell division, and in other type of cells like tumor suppressor genes, whose function is apoptosis, would result in uncontrolled cell division, which forms the basis for cancer formation. Increasing age, our lifestyle that we follow, the environmental exposure that we are exposed to, and our individual genetic makeup also would be adding as the major risk factors for us to develop cancer. So these cancers can be divided into sporadic and hereditary types based on the way the cancers are acquired. Sporadic cancers are those cancers with no inherited genetic variant, but have an increased risk to develop a particular type of cancer. These sporadic cancers are caused by spontaneous mutations that are accumulated over person's lifetime. That is, during the lifetime of the person, the environmental exposure would contribute to the accumulation of these mutations. Usually, sporadic cancers are seen in individuals with no family history of that particular cancer, or in fact, to that point, any other associated cancers also. So, variants, sporadic cancers testing is limited to the tumor itself, and it helps only the individual in whom we test for these variants or mutations. On the other side, hereditary cancers arise due to a genetic variant that is inherited from previous generations. These variants are present in almost all cells of the body and would increase the risk for a particular type of cancer in all the individuals who inherit it. The germline testing of hereditary cancers would help the entire family in identifying the individuals who are at increased risk, understand the surveillance of that particular cancer, and also educates us about the management strategies. If you This slide gives us the information about the mechanism of the cancer predisposition. In sporadic cancers, the individual is born with no inherited genetic mutation. Instead, he acquires different types of mutations in different cells of the body, and which eventually would get accumulated and would result in cancers as the individual uh, grows in age and attains a particular age. Usually, the cancers are seen in older age after sixth decade of the life. Whereas on the other side, in hereditary cancers, the individuals are born with an inherited mutation which is present in all the cells of the body. And eventually, during the course of his life, when he accumulates other type of cancers, the risk for him to develop cancer at an younger age increases. And these individuals with a hereditary cancer mutation inherited have a high risk of developing more than one type of cancer during his lifetime. When we consider all the known cancers, majority of the cancers would be falling under sporadic type, accounting to 60 to 70% of the total cancers. And hereditary cancers just account to a minor percentage of 5 to 10%. And there is another component called familial cancer, which accounts to 15 to 20% of cancers, in which specific clustering cancer clusters are seen in families who follow the same kind of food habits, the same lifestyle they follow, and the same kind of environment that they are exposed to. So there are certain hallmarks of hereditary cancers that can be taken into consideration for identifying them from the sporadic cancers. Those include a young age of diagnosis, multiple generations affected with cancers, specific pattern of cancers occurring in a family, and more than one primary type of cancer seen in the same individual, and certain cancer pathology types that are frequently seen in the family. So these are the hallmarks that identify the cancers to be the hereditary cancers. These hereditary cancers can be categorized into common and rare depending on the incidence that they occur at. Cancer syndromes like hereditary breast and ovarian, hereditary non-polyposis colorectal cancer, familial adenomatous polyposis, Leaf Romani, and men or the multiple endocrine neoplasia come under common hereditary cancer syndromes. Whereas the other type of cancers like retinoblastoma, Peutz-Jeghers syndrome, neurofibromatosis, Cowden syndrome are slightly rare compared to the other type of cancers and are considered as rare hereditary cancer syndromes. This slide gives you the information about the genes that are frequently mutated in specific types of cancers. Towards the right, if you see the breast and ovarian cancer, BRCA1 and BRCA2 are the genes that are frequently mutated that result in breast and ovarian cancers. Apart from these two genes, there are another set of genes like PALB2, CHEK2, TP53, and ATM in the mutations in which also would predispose the individual to develop breast and ovarian cancer. Moving further with colorectal cancers. Colon cancer and rectal cancers are frequently seen together and hence are studied together as colorectal cancers. Colorectal cancers ranks third in terms of incidence and ranks second in terms of cancer mortality worldwide. And it is the main leading cause of death in men below the age of 50 years. According to the recent Globocan studies 2022, colorectal cancers are predicted to rise by 60% in all developed countries by the year 2030. One third of all these colorectal cancers show familial clustering, and 5 to 15% of the cases are associated with germline pathogenic or likely pathogenic variant in colorectal predisposition genetic hereditary cancers. Coming to the risk factors that would contribute to colorectal cancers, these risk factors can be divided into non-modifiable and modifiable risk factors based on the control that we have on these risk factors. Entities like age, personal health history, family history, and genetics come under non-modifiable risk factors, as we individuals have very limited control over these entities. Whereas the other set of risk factors, including body weight, dietary habits, physical activity, smoking, and alcohol consumption, are modifiable risk factors with a moderate level of control by us. All the individuals have an average lifetime risk of developing colorectal cancer for about 3 to 5%. And this 3 to 5% of risk doubles if we have a family history or if we have a first degree relative diagnosed with colorectal cancer diagnosed between 50 to 70 years of age. And this risk triples if the diagnosed first degree relative is diagnosed below the age of 50 years. The increased risk may be attributed to genetics of the individual or the environmental factors that he is exposed to independently or both together. More than half of all the colorectal cancers and the deaths due to colorectal cancers are attributable to modifiable risk factors. The hereditary colorectal cancers can be categorized into two different types based on the clinical features that are seen. The two types of hereditary colorectal cancer categories are hereditary non-polyposis syndromes and hereditary polyposis syndromes. Coming to hereditary non-polyposis syndromes, these account for 3 to 5% of total colorectal cancers. Lynch syndrome forms the major type of non-polyposis syndrome, and the other type of syndrome seen are Turcot syndrome, Muir-Torre syndrome, familial colorectal cancer type X syndrome, Lee-Fromini syndrome. These hereditary non-polyposis syndromes, unlike polyposis syndromes, the polyps development is not that commonly seen, and the polyps that are seen also have a specific type of morphology called pedunculated polyps that are seen in this type of cancer. The second set of colorectal cancers are hereditary polyposis syndromes, as the name itself indicates that the individuals develop hundreds of polyps within the intestinal lining, of which few of the polyps would gain the potential to develop into cancers eventually. About 1% of colorectal cancers fall under this hereditary polyposis type of colorectal cancers. Familial adenomatosis polyposis, or FAP, is the most frequently seen type of colorectal cancer under this type, and the other types includes MUT-YH associated polyps or MAP, MSH3 associated polyps, and so on. Coming to hereditary non-polyposis colorectal cancers, as discussed earlier, as indicated earlier, Lynch syndrome is the most frequent type of hereditary non-polyposis colon cancer, and it follows the autosomal dominant mode of inheritance. It is inherited disorder that increases the risk of many other types of cancers in addition to colorectal cancers. This Lynch syndrome usually is seen in individuals in their fourth or fifth decades of life. Variations in a specific set of genes that are involved in repair mechanism during replication, repair mechanism of replication errors during the DNA replication process called mismatch repair set of genes are responsible for Lynch syndrome. These include genes with the names MLH1, MSH2, MSH6, PMS2, and EPCAM. And the variants, depending upon the gene that is involved in the cancer formation, the risk of the individual developing colorectal cancer also varies. If the variants are seen in genes of MLH1 and MSH2, the tendency, the risk of them developing into colorectal cancer is 70 to 80%. And if the variants occur in the genes like MSH6 or PMS2, the risk is slightly low compared to MLH1 and MSH2 gene mutations, but the risk is around 25 to 60% of cancer. The chance of recurrence also is seen in Lynch syndromes. That is, the chance of recurrence is 15% within the first 10 years after the surgical removal of the colon, and this risk is 40% within 20 years and is 60% after 30 years. Coming to the Lynch syndrome diagnosis, the guidelines for Lynch syndrome diagnosis have undergone many changes over years. Amsterdam criteria and revised Bethesda criteria, which majorly considers the age of diagnosis and the family history, are considered as the guidelines for Lynch syndrome diagnosis. Now, the current guidelines, according to the current NCCN guidelines, including microsatellite instability also has been involved, and inclusion of this microsatellite instability increase the sensitivity and specificity of the diagnosis of Lynch syndrome. So according to the NCCN guidelines, current NCCN guidelines, universally all the Lynch syndrome colorectal cancer should be subjected to immunohistochemical evaluation of MMR genes or the mismatch repair genes for their expression. Any loss of expression in any of these genes labels the cancer as MMR deficient or dMMR, and if the expression is intact, the colorectal cancers are labeled as stable MMR colorectal cancers. And eventually, all the deficient mismatch repair cases should be subjected to germline testing of MMR genes to identify the gene variant that is responsible for the colorectal cancers. Surveillance of Lynch syndrome cases. So early detection can always increase the survival. The surveillance protocol could be personalized according to the genetic alteration and also according to the family history. Colonoscopy remains the main technique for the identification of early stage of colorectal cancers. Annual screening of serum cancer markers like CA-125 also is included in the surveillance of Lynch syndrome. Gynecological surveillance, which includes annual transvaginal ultrasound, should start from the age of 30 to 35 years. Depending upon the gene that is involved in the cancer formation, MLH1, MSH2, and EpCAM mutation carriers should undergo colonoscopy every 1 to 2 years starting from the age of 20 to 25 years. And if the variation is seen in MSH6 and PMS2, because the incidence of these developing into colorectal cancers is slightly less, the colonoscopy can start from the age of 30 to 35 years. Bilateral risk reducing salpingo-oophorectomy also can be included in the surveillance, but it is an individualized option based on several other factors like menopausal history, the childbearing age of the female, etc. Lynch syndrome cases, Lynch syndrome also increases the risk for other type of cancers. Next to the colon cancer, whose risk is 78%, females are at a risk of developing endometrial cancer, and the percentage is 40 to 60% risk. And there is a slight increase for the development of stomach cancers, ovarian cancers, and central nervous system cancers also are seen in a minor percentage of these cases. Coming to the next, hereditary polyposis type of colorectal cancers. As indicated earlier, familial adenomatosis polyposis is the major type of hereditary colorectal cancer, and this accounts to more than 1% of all colorectal cancers, and this is the major cause of polyposis. It is caused by hereditary germline mutations in the APC gene, which regulates the activity of Wnt signaling pathway. Unlike the patients of hereditary non-polyposis colon cancer, FAP patients develop hundreds of polyps, of which few of them undergo malignant transformation and eventually would lead to colorectal cancers. FAP increases the risk of developing colorectal cancers by 100% by the age of 40 years, unless the colon or the rectum is not removed. Extracolonic carcinomas like the gastric cancers, desmoid tumors, epidermoid cysts, and papillary thyroid cancer risk also is high in individuals with APC mutations. Coming to the NCCN guidelines that are to be followed for FAP diagnosis, individuals with positive APC gene mutation should undergo annual colonoscopy starting from the age of 10 to 15. Upper endoscopy to examine the stomach and duodenum, as the stomach gastric ulcers also are seen in these, should be starting from the age of 20 to 25. Annual abdominal palpation to assess the desmoid tumors also becomes important. Abdominal imaging, including CT scan and MRI scans, also may be used for colectomy and may be used after colectomy. Annual thyroid examination and ultrasounds are conducted starting from the teenage for screening for the thyroid cancer syndromes. So if you look at the genes that are involved in the cancer formation and the risk for colorectal cancer that they pose, in the hereditary non-polyposis colorectal cancer among the Lynch syndrome, MLH1 gene poses the higher risk of 46 to 61% lifetime risk of developing colorectal cancers. And in leaf and syndromes like leaf romany, TP53 is the gene, and the risk that it poses is more than 20%. And in hereditary polyposis type of cancer, the APC gene poses 100% of risk for colorectal cancers, and the minor percentage of cancers of adenomatous cancers or hematomas and serrated tumors involving genes like STK1, which results in Peutz-Jeghers syndrome, poses a risk of 39%, and SMAD, which is seen in juvenile polyposis syndrome, poses a risk of more than 50%. So depending upon the gene that is involved, the risk for colorectal cancer also is varying. Coming to the molecular pathways of colorectal cancers, there are three major pathways of genome instability that would eventually be resulting in cancers. The first one is the chromosomal instability, which appears in 70% of sporadic cases. Chromosomal aneuploidy, loss of heterozygosity, and are the common characteristics of this chromosomal instability. Diagnostic tests like karyotyping, fluorescence in situ hybridization, and latest techniques like comparative genomic hybridization, microarray can be employed in assessing these chromosomal instabilities. These chromosomal instabilities contributes to CRC tumorigenesis through the aggregation of mutations in specific oncogenes including BRAF, KRAS, TP53, and APC genes. The other type of genomic instability is the methylation of CpG island methylator phenotype, and this methylation of the CpG island causes transcriptional silencing of the promoter that results in loss of gene expression. This type of promoter methylation is seen in 30 to 35% of colorectal cancers, and a specialized type of promoter studies can be employed in assessing these promoter methylations. The next type is microsatellite instability. As discussed earlier, it is the second most common genomic instability that is contributing to the molecular pathway of colorectal cancer, and it is also used as a prognostic biomarker for colorectal cancers. Immunohistochemical studies and PCR-based testing for markers like BAT25 and BAT26, etc., can be employed in assessing the microsatellite stability. So the testing, PCR-based testing classifies the tumors into MSI low in case if the instability is less than 30%, and MSI high in case if the instability is more than 30%, and if there is no instability seen in the MSA studies of PCR-based MSA studies, then the tumor is considered or labeled as microsatellite stable. Coming to the screening and surveillance, depending upon the family history and the type of the cancer that is seen in the family, the screening and surveillance would alter. If the family has one or more first degree relatives who had colorectal cancer, then the screening and surveillance should be starting from the age of 40 or 10 years before the first diagnosis of the individual with colorectal cancer, and the rescreening should happen once in every 5 years. If the family has colorectal cancer in the second or third degree relatives, then the surveillance should start from the age of 45, and the rescreening should happen once in every 10 years. If the family has a first degree relative who has had an advanced adenoma type of or sessile serrated type of cancers, then the surveillance should start from the age of 40, and the rescreening should happen every 5 to 10 years. Coming to the treatment, the next speaker would be the ideal person to comment and discuss about the treatment options. The usual treatment options include surgical removal, radiotherapy, chemotherapy, followed by targeted therapy or in the immunotherapy. Pharmacological evaluation of genes like DPYD and UGT1A1 helps in chemotherapy in understanding the best suited chemotherapy. And targeted therapy tests are usually based on NGS, that is next generation sequencing. Coming to the prevention of the colorectal cancers, there is no sure way to prevent colorectal cancers, but modifying the risk factors that would contribute to the colorectal cancers, like maintaining a high-rich diet, avoiding smoking, keeping an active lifestyle, limiting alcohol consumption, and avoiding exposure to environmental risk factors could bring a considerable change in preventing colorectal cancers. And there are certain non-invasive stool-based tests called FOBT can also be employed in routine screenings to identify any alterations that are happening in the gut. Genetic counseling stays the important means of prevention, because genetic counseling helps you identify the risk factors, helps you understand the family risk that you have because of your family history, and also educate us about the management strategies that would be helping in preventing colorectal cancers. So there are many advancements that are occurring in the molecular testing of the tumor samples. So conventionally, if you consider the somatic samples are tested for certain mutations in the tumor sample that would be helping us in identifying the targeted therapy options. But if you look at the gene panels that are being employed in somatic testing, a very specific set of genes with targeted therapy option, and the genes and also specific exons and specific fusion sites only are included in the somatic type of cancer panels. This type of somatic testing ideally will not be able to identify the germline mutations. So considering the differences in the methodology that are being employed in somatic testing and the germline testing, variant classification that is being employed, and reporting criteria between germline and somatic strategies, germline variants that would appear will not be seen on somatic testing cancers. Due to the testing design differences, not all the germline variants that are covered in somatic testing, and approximately with the in the specific study that is mentioned above, states that 35% of germline variants are missed on somatic testing, which reduces the options of targeted therapies. So recent literature and many studies highlights the implementation of novel strategies like paid somatic and germline testing for better treatment options. So this highlights the importance of inclusion of genetic counselors as a part of cancer treatment teams to make a difference in the cancer care. So with this, I would like to conclude my presentation. Thank you.
Thank you, ma'am. Thank you for delivering such an insightful and comprehensive session. Your expertise and ability to present the subject matter so clearly was truly commendable. The knowledge you imparted today with us is invaluable. Thank you. Thank you so much. Ma'am, meanwhile, the Q&A session will be followed by Dr. Rajendra sir session. Kindly hold on. Yeah. So now, moving to the next speaker, it is an honor to introduce a remarkable figure in the field of surgical oncology, Dr. Rajendra Baishetty. Dr. Baishetty is a consultant in surgical oncology whose academic and professional journey is a testament to his dedication and expertise in cancer care. Dr. Baishetty began his medical career by earning his MBBS from the prestigious Osmania Medical College. He then went on to complete his MS at JIPMER, followed by DNB from the National Board of Examinations. His pursuit of excellence led him to AIIMS Jodhpur, where he earned an MCH in surgical oncology. Additionally, he has specialized training with a fellowship in minimal access surgery FMAS from AMASI and advanced fellowship in forgot surgeries from South Korea. With over 5 years of experience, Dr. Baishetty has mastered a wide range of advanced cancer surgeries. His expertise includes oncoplastic, breast cancer surgery, cytodeductive surgeries with HIPEC, and minimally invasive procedures for various cancers. He is also highly skilled in complex multi-organ resections and reconstructive surgeries for oral cancers. Thank you for accepting our invitation, sir. Please join me in welcoming Dr. Rajendra Baishetti. Over to you, sir.
I am extremely sorry, guys. So this shows like technologically how much weak we are because we have chosen science over the maths because of this only. So okay. Um, so thank you, Aruna Priya garu, for so nice elaboration about genetic aspects of colon cancer. So now we will see the colorectal cancers, early detection and management. So myself, I am Dr. Rajendra Baishetti, consultant surgical oncology in Sion Cancer Center, Hyderabad. So if you see the basic facts, you can see the image. So that does not mean the marked guy has a colorectal cancer. Just to tell that colorectal cancer is leading in marathon, cancer marathon. So recently it got a bronze medal. That means it got a third level. Previously it was fifth. So that much rapidly it is increasing. Mainly it is in Western countries. So if you see in India, it is the seventh most common. So we are the most populated country. So and here it is the seventh most common. But even though it is a worldwide, it is the third most common. That means imagine how much number of colorectal cancers are there in the Western population. Okay, so that much increase is there. So there is no wonder if it gets the gold medal soon in 2 years. So that much rapidly it is increasing. And if you see, male persons are at higher risk comparing to the female persons. In India, so our southern part and northeast part has a higher colorectal cancer rate. So in the recent incidents, if you see less than 50 years population, colorectal cancer are increasing. So even in the Western data, if you see less than 50 years, colorectal cancer almost the most common malignancy. So that much it is increasing in the younger population. So that is the alarming point, and we have to take care of that. So overall, sporadic cancers are more common than the hereditary cancers. So the risk factors, madam has explained very well. So no need to go into this risk factors. So how the colon cancer presents? So just I put a mark. You can see the colon cancers. You can divide into right side cancers and left side colon cancers. The right side colon cancers, you should keep in mind patient presents with fatigability and weakness. Why? Because right side cancers mostly they bleed more, but the patient cannot understand, like cannot identify that bleeding. So the patient will develop low HB and he developed the anemia. Then patient collapses. So remember the point, above 50 years, patient has unexplained anemia. Think about the right-sided colon cancers. And if you think the left side colon cancers, that means, so this one, the descending colon cancers, here the tumor grows like a lump. So it obstructs the lumen and patient presents it with the obstructive features. So bowel obstructive features. So these are the main signs. So other than that, patient will abdominal pain and bleeding per rectum. So these are the other symptoms of colon cancer. So my today's topic is colon cancer screening. So the screening, early detection is nothing but the screening. So importance of the screening is to identify the cancers at early stage, because the outcomes and the curability, everything depends on the stage of the cancer. If we can find the cancer in an early stage, you can cure the cancer. So that is the reason. So this screening guidelines are implemented. So there are so many screening tests are there for the colon cancer. So in that, some are non-invasive tests and some are invasive tests. So obviously the above one are the invasive tests, where it can be done in only hospital base. The below one are the non-invasive tests. This can be done at the home, but not in India. So these are the kits are there. which are available in the Western countries, they can do at the home. So what are these non-invasive tests which are most commonly done is fecal occult blood test. So fecal occult blood means, so as I told, in the right-sided colon cancers, the cancer bleeds very slowly. So then the patient cannot identify the bleeding. So that's why the occult bleed, which cannot be seen by the naked eyes, can be identified with this test. The most common test is rehydrated guaiac test. And one more, next one is fecal immunochemical test. So what is this immunochemical test? So when the bleeding is there, so as everyone knows, it has the hemoglobin, it has the heme molecules. So that heme molecules we can identify in the fecal matter. So that with that, so we can find out the patients who are at risk for the cancer. So the next one is fecal DNA testing. So we will go this one by one. So fecal DNA test. Other invasive tests are endoscopies. Means like the colonoscopy, sigmoidoscopy. That means you are putting camera inside the colon and you are observing where the growth is there. So we will go one by one. So these are the American guidelines. So how to screen? So those who have crossed 45 years will be considered as the average risk adults. So for them, you can do any of this. No need of doing all the tests. So any of this we can follow. So the first one is every yearly you have to do fecal occult blood test or fecal immunochemical test. So this is most commonly done because this is a non-invasive test. And multi-targeted stool DNA testing every 3 years, and sigmoidoscopy every 5 years, or colonoscopy every 10 years. So remaining double contrast barium enema nowadays we are not doing, and CT colonography. So I'm going one by one. Stool DNA testing means here, so some cancer cells are shed in the fecal matter. So from the shed cells, so we can find the mutations or the DNA sequences. So for example, the methylated BMP protein or NDRG4 promoters or mutant KRAS genes. So like this, so many are there. So that you can find out in the fecal matter, and you can find either colorectal polyps or colorectal cancer. So actually this is the emerging modality. So in the future, so it may take over all the tests because it has a very good sensitivity. You can see here the highlighting, because now the FIT, that means fecal immunochemical test, which is being done most commonly, and the future stool DNA test. If you see in the cancer, 93% sensitivity is there for the stool DNA test, when comparing 73% only for the fecal immunochemical test. And if you see for the precancerous lesions, so 42% is there for stool DNA, and only 23% for the fecal immunochemical test. So there, till now we discussed non-invasive test. So if any non-invasive test comes positive, that means the patient is bleeding. That does not mean the patient has the cancer. So again, you have to take for the colonoscopy to see what is the reason for the bleeding. So again, the colonoscopy is a modality for the screening. So in this colonoscopy, directly we'll put the camera inside, and we can see inside the lumen mucosa where the growths are there or any polyps are there, that you can see. In this colonoscopy, so many techniques are there to identify the early lesions. So for some examples, like chromoendoscopy. So chromoendoscopy means, so while seeing the inside the mucosa or inside the lumen, we put some dyes. So it exactly opposite to our human makeup. To hide the pimples or marks, we put the fair and lovely or whatever. So nicely it hides the marks. But here exactly, if the tumor is there, you will put the stain on top of that. So where the tumor is there, so either it does not take or it takes over this dye. So it clearly visible. So in the makeup, it marks the pimples, but here it dye, it makes clearly visible of lesions. So normal colonoscopy, up to 20 to 25% of the small lesions, there is a possibility to miss. But in chromoendoscopy, that missing lesions, you can identify with high accuracy. So here you can see, so in between that methylene blue was put. So we can use Lugol's iodine or methylene blue. So here the concept is just imagine iodine. Cancer cells has a low glucose, low glycogen stores comparing to the surrounding cells. So iodine, if you put, so it gives the, if you put on the glycogen or glucose, it gives the color. Everybody knows that. So when cancer tumor is there, there the low glucose levels are there. So it won't give any color near the cancer, excepting surrounding it gives the iodine color. So like that, acetic acid is there. So carmine red, like that, so many stains are there. You can just spill over the mucosa and you can identify the new lesions. Other technique is narrowband imaging. So you can see in the image there is a rainbow. So in the light white color, it has the 7 VIBGR colors. So here the concept is, so dividing that, if you are able to see one color like red color, that means out of the VIBGR, remaining colors are observed and only red is being reflected. So you are able to see the red color. So here, that's why in the out of the VIBGR, remaining all colors we are blocking before only, and we are projecting the light, blue light and green light on the mucosa. So where the blood vessels are there, so blood vessels are there, it does not take any color, and you can see the lesions like this. So if you see in the normal colonoscopy, this is the lesion, and if you see in the narrowband imaging, this is the lesion. So the small lesions are which are not visible to the naked eye, you can see better in the narrowband imaging. So here you can see this is the magnified endoscopy with the narrowband imaging. So this is inside the stomach near the pylorus. So that small one, all vessels, microvasculature. Normal cancers will have a more vasculature, so you can identify easily where the lesions are there. This is other technique of screening, that is the CT colonography or the virtual colonoscopy. So this is the beauty of artificial intelligence or the software. Just we are doing the CT scan, and with the CT scan we are virtually re-imaging and making a image of colon. In that you can see the image, like if any polyps are there, you can nicely identify. Above 5 lesions, everything you can identify with a virtual colonoscopy, and without invasive test, like without doing colonoscopy, you can find out these small lesions. Then, so these many tests are there, screening guidelines we have seen. Then what is the advantage of this screening is, overall, if you see 20 to 30%, previous studies are showing 20 to 30% reduction is there in the colon cancer incidence. So that means new cases reporting 20% reduced, and in the mortality has reduced up to 25 to 30% in the old studies. So this is for the patient and it improves the quality of life. And if you see the society wise, it increases the life years saved. That is, economical benefit will be there if you see from the government perspective if they are doing screening. And this is a screening for the high risk patients. So madam has told nicely about this, how to do this screening for those who are those who have a familial risk and those who have a syndromic. So in that this no need to mention, I think. But if you have a familial FAP syndrome, if you are suspecting, the screening will be started at earliest 10 to 12 years of age. And in the Lynch syndrome, so as early as it will be started at 20 to 25 years of age. And everywhere you see some exceptionist will be there. So till now we have discussed so many tests, but there people will be there, those who does not want to do anything. They don't want non-invasive test, invasive test. So for that type of people, one more test was recently approved, that is methylated septin 9. So this is like a blood test only. So colon cancer has this methylated septin 9 levels. So when you are taking the blood test, we can find this septin 9, and we can find whether colon cancer started or not. But the sensitivity is very less, because in out of 5 liters blood, finding this septin 9 proteins, how many will be there? And if you are taking 5 ml of blood out of that, so if it has septin 9 or not, we don't know. So that's why the sensitivity is very less. So till now we have seen the screening. So going for the management of colon cancer, to understand the management, you should understand the stages of the colon cancer. As everybody knows, cancer has the 4 stages in every cancer. So in the stage 1 cancer means it is just confined into inside the lumen. Stage 2 means so it not only to the colon, surrounding structures also it is infiltrated. Stage 3 means from the colon, it is metastasized to the lymph nodes. This is a one point everybody has to remember, the lymph node, it has metastasized to the lymph nodes. Stage 4 means it has gone to the liver, bone or lungs, wherever. Other organs are involved, that is the stage 4. So in a stage 3, as I told, tumor is somewhere in the lumen. So it has spread to the lymph nodes. So here 3 levels of lymph nodes will be there to understand the further management. So if you see the red color, they are called pericolic lymph nodes. That is a level 1. And if you see the blue, so that is a level 2. So that is intermediate lymph nodes. So yellow ones are the principal nodes, are level 3 nodes. So that will come soon. Any cancer, so there are only 3 types of management will be there: surgery, chemotherapy, radiotherapy. So if you are giving chemotherapy or radiotherapy before surgery, it will be called neoadjuvant. If you are giving after surgery, it will be called adjuvant. Okay, so how it is going to be done? So don't get scared by seeing this. Just I put like, if the colon cancer is operable, just first operate it. Okay, if the cancer is not operable, then think about the chemotherapy. Okay, so that's why I put that. Whether patient has obstruction to the bowel, or there is no obstruction also. If it is operable, just go and operate it. That is the main funda, there is main management. Then after surgery, we will give chemotherapy. Okay, but what are the recent techniques in this management? If the lesion in T1 lesion, if it is very small, that means inside the lumen, small 1 to 2 centimeter tumors are there. So that tumors we can manage with the endoscopy itself. We no need to do the surgery. We no need to open the abdomen. So that is one technique is snare polypectomy. So that polyp is inside. So whether you have identified in colonoscopy or whether you have identified in virtual colonography. So you can do this. You see there is a polyp is there. So underneath it, they inject the normal saline and they are doing that snare polypectomy. So with the snare, that wire they are putting it and they are cutting, they will remove it out and send for the further testing. So that is the snare polypectomy. That is the one technique for the very early stage cancers. And one more is this is endoscopic submucosal dissection. This is also done through colonoscopy only. So here you can see colonoscopically where the small lesion is there. So they are doing this. So here also same, they have injected saline underneath it and they are trying to resect it. You can see the final specimen after resection. But in India, the bad luck is it is too difficult to get the cases who are in early stage. So this is only possible in South Korea where I went. I have seen these videos I have shot there only. So in Japan, South Korea, in Eastern countries, so there the screening protocols are followed very nicely. So in India, if you are asking for the screening protocol, they will tell the doctor is asking to take money only. So it's not like that. So screening so identifies the cancers early and it helps to do the procedures in this endoscopically alone. So if it is gone beyond the stage 2 or stage 3, so obviously you have to go for the surgery. The main surgery is, so wherever the cancer is there, you have to resect the part and you have to reanastomose the bowel. So you can see the reanastomosed bowel in the image. Here the concept is, so wherever the tumor is there, so if the tumor is here, this side at least 5 centimeter and distal to that 5 centimeters, we have to take the margin and we have to resect it. That are they are the guidelines. But in the colon has from ascending colon, transverse colon, descending colon, sigmoid colon. So wherever the tumor is there, so the resection depends on the blood supply. So if it is the right side, it will be called right hemicolectomy. If it is the left side, so it will be called as a left hemicolectomy. And if it is in the mid, so it will be called a transverse colectomy. So if it is in the sigmoid part, it will be called sigmoid colectomy. Ectomy means you are removing and throwing out. That is the ectomy. So whichever colon you are removing, you can put like that. That is ectomy. So you can see here the right side mass is there, right colectomy. So if the mass is little higher up, so you have to do right extended hemicolectomy. So this you can see the images here. So this is the right side cancer. So where we have removed right side colon. So this is the right hemicolectomy specimen. So this is the left hemicolectomy specimen. You can like imagine the left side colon. So this is a segmental colectomy. Here you can see the mass in the sigmoid colon. So here both sides the margin has given and we have cut it. So we can call it as sigmoid colectomy or you can call it as a segmental colectomy. So whatever. And these are the lymph nodes. So that will next we'll discuss about that. So this is the sigmoid colectomy or anterior resection. So previous one you can see the little tumor is higher up. So this is small part removing is also enough. But here you can see tumor is little higher, little down. So you have to remove little rectum also. Then it will be called anterior resection. So what are the advances in this surgery? So this surgery is being done since decades. So the new concept is doing D3 dissection or complete mesocolic excision. These are the new concepts. So European fellow calls it as CME with CVL. The same Japanese, he calls it as the D3 resection. But the both concept and the benefits are both are same. So here the concept is, so as I told, we are doing right hemicolectomy. So the lymph nodes, as I told, 3 stations are there. Okay. So we have to remove even third level lymph nodes. So that is D3. Third level means the D3 lymph nodes. So you can see D3 is the greener lymph nodes. So whichever colon we are removing, so we have to remove the D3 third level lymph nodes also. So that is only the D3 dissection. So these are the principles like mostly may not required for you, but that lymph node dissection depending on the stage. So we decide whether to do level 1 dissection or level 2 or level 3. So like that. So is the D3 lymph node dissection has any advantage? Yeah, there is the survival advantage. So that's why the newly everybody is telling D3 lymph node dissection has to be done for the advanced cancers. So that D3 Japanese fellow is calling D3, but the same European fellow calling it as complete mesocolic excision. So that is also almost the concept is same. So here colon along with that the blood supplying vessels, so everything has to be cleared properly. So that is complete mesocolic, that word meaning itself complete mesocolic excision. So you can see here how nicely blood vessel is skeletonized. That means the fat around it, it is removed before ligation. So that is called central venous ligation. So you can see like this in this is also right hemicolectomy specimen. This is also right hemicolectomy specimen. But here you can see there is no fat at all. But here you can see properly the fat has gone here. You can see the vessels also. So here it is called D3 dissection is done here. So then the advantage is the more number of lymph nodes are removed along with the specimen. So the more survival advantage will be there, because if that involved lymph nodes will be removed obviously. So the new other advances are minimally invasive surgery. So minimally invasive means doing laparoscopy or robotically. So laparoscopically it is approved long back. So before without giving incision, so just we will put the laparoscopic ports. So depending on which colon we are removing. So but at the end the problem is it is a cancerous bowel. So to remove it out, you have to open it. If it's a benign one, you can grind inside the body and you can remove it. But it is a cancerous one, you cannot grind. If you are grinding it, you will spill over the bowel. So finally, you have to make a small incision. So this is called wound manager or Alex. So we put that and we will remove out. So you see, this is the difference. So this is laparoscopically, it is surgery is done and specimen is removed from the small incision here. So this is the midline wound, where the surgery is done. So this is the difference between laparoscopic and open. But what are the advantages? Is there only cosmetic benefit of laparoscopic surgery? No, these are all the trials which have proven that laparoscopy is non-inferior to the open. No study has proven that laparoscopy is superior to the open surgery. Oncologically, it is non-inferior only. That means you can consider. But what are the benefits if you think? Less blood loss, so very short hospital stay. So obviously you are giving very less incision, so patient can go on second day or third day home, and quicker return of bowel functions. But the problem is when you are doing laparoscopy, so obviously it will take more time. So if you are eating with fork, it will take more time when you are eating with the hand, comparing with the hand. So that is exactly here. The robotic surgery, so it is approved, robotic is also accepted, and it is also proven non-inferior to the open surgeries. But only the problem is amount, cost of the surgery. So that is the reason most of the surgeons prefer laparoscopy over the robotics, because the robot itself it costs 14 to 15 lakhs. Now cheaper versions came which are 7 crores. The original one is 14 to 15 crores. So obviously the cost will be more. Once surgery is over, we give the chemotherapy. So this is all may not required for you what chemotherapy we give and how many months we give the chemotherapy. Depending on the after surgery, that stage we will come to know exactly. Depending on that we give. Whether before surgery can we give the chemotherapy, so that Foxtrot trial is going on. It has also proven non-inferior only, but the result has yet to come. So till now we have discussed stage 1, 2 and 3. What about the stage 4? So stage 4 means the cancer has spread to all over the body, either liver to the lung. So in this, where the new therapies are came, targeted therapy. That means whichever the gene is involved, so against that gene, you will give the mutation. You will give the drug. So there are FDA approved are EGFR inhibitors, vascular endothelial growth factor inhibitors, BRAF inhibitors, and HER2 drugs are there. But one thing everybody has to remember is, so everybody know, I think this is cell proliferation cycle. So when EGFR mutation is there, so we are giving the EGFR drugs. But the problem is we have to see the KRAS mutation, because in this cycle, so it's like a EGFR is a owner, so KRAS is an employee. But when employee has taken over the charge as a owner and he is acting as a owner, because of the KRAS mutation, the cell proliferation is going on. So when employee is working as a owner, then no point acting on the owner. So this is exactly when KRAS mutation is there, no point giving EGFR mutations, anti-EGFR drugs. So that's why you should find KRAS mutation is there or not before giving any targeted therapy. And if BRAF mutations are there, so many drugs are there, vemurafenib and all. So depending on the mutation, you can consider. And one more recent one is immunotherapy, so which is very costly. But the concept is, it is acting on your immune system, like whatever cancer patient's immune system, and it is helping cancer patients T cells to act on the cancer cells. So that is the immunotherapy. Here it is approved in MSI high patients, and it has proven that it improved the survival benefit also. So there is the keynote trial where pembrolizumab was done. So till now we are telling injections we can give, but is there any surgery role in metastasis? Yes, there is obviously there is a role. So when metastasis is there, initially we give the chemotherapy. So if the tumor is responding nicely, so wherever the metastasis is there, we will try to remove it off. So you can see this is the right lobe of the liver where the tumor is there. So entire right lobe is removed. And this is left lung, lung lobectomy. So if the metastasis is in there in lung also, so we never hesitate to remove lung lobe also. So you can see the view, the post-surgery resection, the inside heart is beating and aorta is there. So that is post removal of left lower lobe. And till now we have discussed about colon cancers. rectal cancers, how is it is different from the colon cancer? Other than that, most of the things are same. So in the colon cancer, it is in the most distal part. So till we have seen, like, we have to resect the tumor and we have to anastomosis. But if the tumor itself is at the distal part, where is what you can anastomose distally? So nothing you can anastomose. So in that situation, we completely remove the distal part. We put it as a stoma. This large bowel, we bring it out and we put it as a stoma. That will be the permanent stoma. So the patient has to accept that. And but in India, the still patient has so much stigma to accept the stoma. So people are not accepting this surgery, but there is no option. Okay. And in the surgery, this is one more latest is transanal endoscopic microsurgery. So instead of putting holes in the abdomen, so through the anus itself, we are putting the scope and we are operating it. So where the small tumors are there or small polyps are there, so we can do this transanal endoscopic microsurgery. This is the scarless surgery and it has proven good benefits in early stage cancers. Till now, in colon, radiotherapy does not work, but in rectum, so radiotherapy works very beautifully. So any T3 or nodal metastasis is there, we have to give the radiotherapy before doing the surgery. That gives a very good benefit. And this is the last concept, only 2-3 slides are there. What are the colonic stents? So if inside lumen there is a cancer growth is there, obviously it will obstruct the lumen. Then patient went into the intestinal obstruction. That needs the immediate surgery. But this type of patients will already in stage 4, those who are already debiliated, they cannot fit for the surgery also. In that patients, we put the stents inside to relieve the obstructions. So these are the stents. So we put transanally, we will go inside and we will put. So you can see the growth here. So we put the stent inside and we inflate the stent. So the lumen will be opened again and obstruction will be relieved. You can see. So because of the obstruction, there are so many air fluid levels are there here. So once we inserted the stent, so entire air fluid levels has gone, patient relieved the obstruction. But this will be done in the patient who are not fit for the surgery or who can be taken up for the major surgery. Before the few months, we can put this stent and we can manage. Thank you.
Thank you, sir. It's a phenomenal presentation, sir. It's fantastic. So it's an exceptional talk. It's not just informative, but also creatively illustrated with lots of engaging images that made everything so easy to understand. From the screening methods to the advanced treatment options and what are the kind of surgeries. It's excellent, sir. Excellent. Thank you so much for accepting our invitation and giving the talk. It was fantastic. And we'll move to Q&A session. So if any questions are there, please raise your hands. We'll unmute, or else you can use the chat box. Sir, I think there is a question for Dr. Rajendra, sir. Dr. Rajendra, is our IRE or a nano knife procedure possible for colorectal cancers depending on its stages? Sir, am I audible?
Yes, Krishna, it's audible. Yeah, nano knife means like in the colon cancer perspective, I'm listening first time. I think that endoscopically what we are resecting might be called as nano knife, I think. But I never heard that nano knife procedures.
Then what are the limitations for accepting specific surgery? Nikita Javale.
So limitations can be different amounts, like either like in a financial perspective or the disease perspective. In the disease perspective, again depends on the person. So if you go to the chemotherapy person, he will tell, yeah, we can deal with the chemotherapy. If you come to the surgical oncologist will tell like the surgery can be done and it can be removed. Only thing you have to see is how much benefit you get out of it. So as I've shown, right hepatectomy I have shown you. So 60 years or 70 years, so we don't go for the right hepatectomy because that surgery itself is a very morbid procedure. Young patients, so those we can give at least 10 years of life by doing surgery, we will go with the morbid surgeries. So other than that, like main lung resections, liver resections, remaining all can be done in the 80 years also. So there is no limitation for that.
She's continuing with the questions. The surgery methods are only colorectal or brain tumor, likewise other types of cancers.
Yeah, depending on the cancer, we use the method. As I mentioned, there are 3 methods are there: surgery, chemotherapy, radiotherapy. Chemotherapy alone can never cure the cancer. Remember this point. So either you have to use radiotherapy or the surgery, which both are the local therapies. So, but for some cancers, radiotherapy can cure it. For example, squamous cell carcinoma of cervix, or even as you mentioned, the brain tumors. Brain tumors, depending on if the metastasis is there to the brain, we give the radiotherapy and we'll try to cure. If only primary is there, like a glioma, then you can resect it. But again, outcomes will vary. So in brain tumors, mostly we do the surgery, followed by again we give the radiotherapy. Yeah, I think Magnesh has asked, IRE is irreversible electroporation. Yeah, this was actually more than 3 years I worked on this electroporation. So the word IRE I didn't understand, but electroporation does not uh, completely resect the tumor or completely ablate the tumor. Okay, only in the stage 4 cancers where the patient is symptomatic because of the cancer, patient is having pain or other features, we give the irreversible electroporation to that. So in colon, if you give the electroporation, that means you are putting the probe inside and you are just burning it. Obviously, the colon will open it. Then the patient, like entire fecal matter will spread into the abdomen. So irreversible electroporation you cannot give to the colon or any bowel, any lumen structure. But if the same one, if it is in the liver or pancreas, solid structures, in a solid structures you can use irreversible electroporation. But so FDA has not yet approved. So remember that still the pancreas, the studies are going on for the irreversible electroporation.
Got it, sir. And there is a question for Dr. Aruna ma'am. Is breast screening also necessary for colon cancer positive patients?
Yes, the screening program usually should also consider the family history. So, considering the family history, if the family history shows the history of breast cancer in certain other family members, definitely it has to be included into the screening regime. So, can I put a question to Dr. Rajendra?
Yes, madam.
So that was a very clear and detailed explanation. So may I ask you what is the youngest colon cancer case that you have seen in your experience?
Youngest colon cancer, I think 20 to 20, no, madam, 19. But that was a rectal cancer. We have operated, madam, 19 years. So it was in Jodhpur. So that guy also like got married 6 months back only. But
Nice.
after this one, we have given even radiotherapy, madam. But within the 6 months, he got recurrence. So it was like very bad. Still, I can remember him. So he
Oh,
used to suffer a lot because of the recurrence.
yes.
So he used to have a very bad pain. So that was 19 years.
Okay.
And breast cancer, the youngest is the 13 years old. We have operated, madam.
Oh, 13-year-old.
13-year
Any
old.
other family history also seen in her
She
family, sir?
she does not have any family history, madam. But I think at the age of 8, she has a lump and she got operated. We didn't have any reports of that. But at the age of 13, we did the biopsy. We came to know it is a cancer. Uh, But to preserve the breast, we have done, so just part of the breast we removed and we have done this one flap, free flap to give again breast shape. So, but bad luck is the corona time. So she got the corona. Then after 1 week only we operated. So that flap got necrosed.
Oh, okay.
So then we removed the entire breast for her at the age of 13. So that is a bad luck. But so because of her, we learned the new lesson that corona is leading to microvessel thrombosis. That is the reason her flap got necrosed. So we learned a lesson from her, but she lost a breast, one breast.
I think Corona has taught many lessons.
So many lessons, madam. This is, as a surgeon, I learned it.
Great, sir.
Yeah. So, Janavi, what steps can be taken post-surgery to prevent recurrence of colorectal cancer? Yeah. Post-surgery, we are giving the chemotherapy that is called adjuvant chemotherapy. Why we are giving that therapy is to prevent the recurrence only. Whenever we are getting a cancer, so many microcells, that is called interstitial tumor cells, ITC cells, enter into the blood circulation before we are removing itself or while removing it. That interstitial cells will roam in the blood. So whenever the favorable environment comes, favorable time comes, so it enter into the either lung or liver and it grows as a tumor. That is called metastasis, what we are seeing. So to kill that microcells, we are giving the chemotherapy. One thing. Second thing is, even if you give chemotherapy also, some people will get recurrence. So to find the early, we are doing the follow-up. No cancer patient just after surgery, we will leave them. So every 3 months we follow up, we do the scan to find out if any recurrence is there and to operate early. So that is called surveillance, as madam mentioned, and that is called follow-up what we are doing.
And I think there is a question from Jonah Daniel. Thank you to the both Dr. Aruna ma'am and Dr. Rajendra sir for such an informative sessions. My question is to Dr. Aruna ma'am. Any difference in the incidence of colon cancer among male and female?
Yes. As Dr. Rajendra also has rightly mentioned it, literature says that the men are at a slightly increased risk for colorectal cancers compared to females.
Got it. Then we have a question from Shubham. Sir, if the gut, I think it's for Dr. Rajan sir, if the gut microbes will influence the occurrence of colon cancer, or how gut bacteria will help to manage the cancer before, on and after the cancer?
Yeah, it was a huge lesson. The microbiota of colon, how it is affecting the cancer. There are two types of bacteria is there. That is good bacteria and bad bacteria. So good bacteria, which is helping us to prevent the cancer, and some bacteria are there which increases. So, but some bacteria, for example, I will tell the bacillus. So, which is the probacteria and a good bacteria which is helping us. Some other bacteria are there which will cause the damage to the endothelium. So, the recurrent damage to the endothelium or the mucosa, which is leading to the cancers, and one type. And some other bacteria are there, corynebacterium and all, which can cause the mutations inside the cell, which can lead to the cancer. So like that, the good bacteria is there, bad bacteria is there.
Got it, sir. I think, ma'am, can you please comment on it? Because we have discussed this about. Aruna, ma'am, can you please? Yeah.
I think gut microbiota in a way increases the inflammation, which is considered as a risk factor for cancers. So that could be the thing that can be considered.
Got it, ma'am. So I think Jahnavi also asked the same question. How does gut microbiome health influence colorectal cancer risk and treatment outcomes? I think the answer has been seen. Any questions?
Okay, Krishna, I think there are no further questions.
Sir, I think there is questions in Q&A, sir. Let me check. Somebody is
Yeah,
messaging.
VEGF treatment, yeah, vascular endothelial growth factor, VEGF. So what we give is anti-VEGF. So whenever the cancer is forming, it forms the new blood vessels to survive. Uh, so that new blood vessel formation is called neovascularization. So for the neovascularization, this vascular endothelial growth factor is required. So we give bevacizumab, which is anti-VEGF, which blocks this receptor, VEGFR receptor. So that blocks the neovascularization. Because of that, the tumor went into hypoxia, or it decreases the nutrient supply to the tumor and it kills the tumor.
Sir, we got a question. How do advancement in immunotherapy and targeted therapy influence the treatment options for particularly colon cancer patients, particularly those with metastatic diseases?
No, I didn't get you, Krishna. Please repeat again.
How do advancement in immunotherapy and targeted therapy influence the treatment options for colon cancer patients, particularly those with metastatic disease?
Yes, like what we are doing, what we are practicing is evidence-based medicine. Okay, till now the study trials are done for the stage 4 patients, this immunotherapy and targeted therapy. That's why till now it is approved in only stage 4. That does not mean it does not work in the stage 2 and stage 3. Still the trials are going on, but today morning itself one trial is published where in colon cancer, if it is, that is a European guideline, madam. If it is MSI high, you can directly upfront give the this one pembrolizumab. Today itself it is approved in European guidelines. So the future it is going to come as a neoadjuvant therapy, but right now it is given in the only metastatic setting. So how it is going to get benefit? One thing, in a routine cancer therapy which has so many complications or side effects, immunotherapy does not have that side effects. One thing. Second thing is immunotherapy has given a good survival, overall survival. That means the stage 4 patients. So if you think like the patient will survive for 1 year, if you put the immunotherapy, patient will survive for 2 to 3 years. So just on average, I'm telling, it varies, depends on the cancer. So that means it has given the survival benefit. But the problem is immunotherapy is very costly because it is now only it is being released into the market and so many companies has the patent rights. So until this patent goes off, so the amount has to be paid a lot. So that is a drawback with the immunotherapy or targeted therapy.
Got it, sir. Sir, actually, I have a question. You have mentioned that the people of South Korea, like Japan, the countries like Japan, has been a lot of good screening programs, and they have sustainable, policies regarding the things. But what do you think that within the growing awareness of early onset colon cancers, because we are seeing a lot of people with early onset of colon cancers, especially in younger populations, how are these screening guidelines evolving, and what preventative measures should be emphasized for those under the age of 50, sir?
Yeah. So when a screening protocol, like if someone is writing the guidelines, what we think is cost benefit ratio. So if I am advising you, like if as a, like I am sitting in the government panel and I am advising you to take a screening test, okay, how much I am going per year, how much I am going to spend on this cancer screening, and how much benefit I am getting. I told as a community level, years earned, okay, now quality years earned, how much I am going to get. So this analysis will be done and government will decide. So as if you take the examples of polio or cervical cancer, so everything previously this rate was very high. So we are the developing country. So that's why like when that load was very high, we have spent so much money on the polio and this CS cervix. No, that is reduced. So, but if the government has a sufficient money, they will obviously they will spend on different screening protocols or guidelines, whatever. That's why like community wise, like publicly, if you want to so apply the guidelines, it's too difficult. So in Japan or in South Korea, so where actually these gut cancers are more. So that is the reason every yearly, so the government, like they will, it does that free of cost for everyone. So in India, it's difficult now for free of cost. It's impossible to this much population.
Got it, sir. Sir, I think one more last question. How are emerging molecular profiling techniques such as liquid biopsies being integrated into personalized treatment plans for colon cancer patients?
Yeah. So liquid biopsy is there, but as I mentioned, out of 5 liters blood, so how if you are taking 5 to 10 ml sample. So in that, what is the probability of being that mutation or gene? So that is the first question. That's why the liquid biopsy sensitivity is very low. So if liquid biopsy is negative, that does not mean you cannot tell inside the tumor is not there. Okay. So the what else next question regarding liquid biopsy?
Being integrated into personalized treatment plans for colon cancer patients.
No, exactly. From the tumor, we are taking the tissue. So we are taking the mutations. Like as I mentioned, like KRAS mutations are there or not, BRAF mutations are there or not. So these all you are seeing. So from same liquid biopsy, you can take the sample. So you can find it. So whether that mutations are there or not. So depending on that, you can give the treatment. But we cannot trust that much. But when you don't have the tumor sample, for example, I will tell, so previously patient was operated somewhere else and the sample was misplaced somewhere. You don't have the samples. Then you will try to take the liquid biopsy sample and you will try to process it if you can get any DNA from out of it. Okay. But don't know, like some tests, like future tests has to come where the sensitivity has to increase. Then liquid biopsy may come in the future.
Right, sir. Got it. I think.
But as of now, liquid biopsy, people are using it for the follow-up. So once the like surgery is done, therapies, everything is done. So in a foreign, people are using liquid biopsy for the follow-up. So if liquid biopsy does not have any like the old cancer gene mutation or any old cancer gene sequence, so that shows that molecular complete response.
Right. It's a
So
kind of a
is it to
screening.
keep an eye on the recurrence, sir?
Yes, madam. So we have to keep. So any patient either from stage 1 to 3, we keep on follow up to 5 years according to the guidelines. In the first 2 years, every 3 months we call the patient and we examine clinically. If required, we get the testing done. So after 2 years, again we'll change to 6 months follow up, madam, up to 5 years. So within the 5 years, if the cancer has not recurred, that means you can assure the patient like 95 to 99%, there is no probability to get again.
Is liquid biopsy being employed in assessing these recurrences?
Yes, madam. So for the follow-up only recurrences, no, it is being used.
Oh, thank you.
So just as a screening protocol, we can use it as a screening protocol soon after the surgery.
Not screening. Screening is different. Follow-up is different, Krishna.
Okay.
Screening before diagnosis of cancer, you are doing it screening. Okay. After once the diagnosis is done, you it will be called as the follow-up and surveillance, whatever. So in that it will be used liquid biopsy.
Screening is done in undiagnosed cases, Krishna.
Got it.
And one, I think Nikita Jawala, after removing liver lobe in cancer surgery, what are the chances of getting reoccurrence of cancer in the regenerated natural liver lobes? And what are the other parameters need to undertaken before the cancer is? Okay, so good question, Nikita. When we are doing the surgery, we see the 3 factors mainly. One, operability of the tumor. If the cancer can be removed by resecting it, whether we can remove it or not. Then patient fitness we see. Okay. Patient performance should be very good. So depending on the surgery, if it is a small surgery, it's fine, but most of the surgeries are long-standing surgeries and the surgery effect will be more. So we see that patient performance status, that means lung capacity, kidney and liver functioning, how it is there we see. And echo also to see the cardiac function mainly. and how much benefit it will give the patient by doing surgery. So that also we consider before taking for surgery. And in the new, like only liver has a regenerating capacity. If you remove half of the lobe, so some part it will regenerate, obviously. But in regenerated lobe also, there is a probability. As I told, there are microcells are there. So many microcells which are roaming in the blood. They are the villains. So after forming new liver also, so if it finds there favorable environment in the new liver, it will come and it will form tumor there also. So there is a probability. We cannot tell no. Yeah, Magnesh, Dostarli map. Yeah, it is a very good question. So I have to tell this one story of the Dostarli map. Dostarli map was given in the rectal cancers for the 14 patients, and after giving certain time, they have mentioned, they have published a trial. There is 100% it is tumor is disappeared, but I will tell the secrets of this. That study is funded by the company which is being prepared by the Dostarli map. So that is Rotiro, something is their company. So that is the first reason. And second reason, by doing scan, you cannot tell the complete tumor is disappeared. Always, you have to remove the that organ and see pathologically. Clinically, response is different. Pathological response is different. In a Dostarlimab study, there was nowhere it is proven as pathologically responded. So they mentioned 14 people out of 14 clinically responded, but the study is funded by the company which has the got patent rights of Dostarlimab. So we cannot trust the findings. Next, how are the emerging molecular problems such as liquid? Okay, that's over. One more question: what are the chances of occurring cancer like after 20 years later complete treatment? But I didn't understand. What are the chances of occurrence cancers like after 20 to 25 years later complete treatment, but it reappears?
All of 5 years, I guess. 20-25 years tarvata etla recover avutundi.
No, I told na. So there, like in a liver, like if you think about the liver cancer, so entire liver is affected by the like whatever pathogen or the etiological factor. For example, so asbestos is like or some factor is there, some X factor. If you have taken the X factor, entire liver will get exposed. Okay, so now right lobe of the liver got the cancer, you have removed the right lobe. What about the left lobe? So it has already affected to that. So there is a probability left side you may get the cancer at any point of the time. That is first explanation for the liver cancers. But for other cancers, as I told, there are the interstitial tumor cells, circulating tumor cells. So which are already entered into the circulation and which is roaming in the blood. So that can deposit in the liver or lung after 20 years, after 50 years also, because it roams there until a favorable environment comes to that cell. So during that journey, if your immune system kills that cell, very happy, you like patient may not get the recurrence. But if the tumor cell has the capacity to evade the immune system, it hides from the immune system and it roams in the blood circulation. That capacity cancer cell has. So it can get at any after 20 or after 50 also it can come. So there is no wonder.
Got it, sir. Such an extraordinary explanation, sir. I think no more questions. Sir, I think one last question from Q&A. I think, sir, if a patient is detected with a particular mutation, this mutation had FDA approved therapy, then for how long the patient should receive targeted therapy?
No, in a stage 4, there is no time until the patient survive, like alive, you have to give. So there is no protocol. But even if in stage 1 and 3, up to 3, 1 to 3, you can give up certain cycles, like normally depending on breast cancer, 8 cycles are approved. In ovary, 6 cycles are approved. Routinely, all cancers will have a 6 cycles. But in stage 4, that is already metastasized. That means in a stage 4, there is no cure. So you have to give this therapy until patient is alive.
Got it, sir. I think the Q&A session has been ended up with that question. Thank you, sir. Thank you so much for accepting and giving the incredible presentation. And as the same, Aruna ma'am, thank you for accepting and giving the presentation. I think.
Thank you, Dr. Rajendra.
Yes, ma'am. I think one more question.
Nikita? Yeah. Yeah, so body has thousands of lymph nodes. So if you are operating for one organ, so maximum of that organ will have 25 to 26 lymph nodes will be removed. So that does not affect the immunity. One thing. Second thing is, so the lymphoid pathway, that is what you are disturbing is the lymphoid pathway. From the organ, the lymph will be taken back to the blood through this lymphoid pathway. You are disturbing that pathway. So some lymph will be released surrounding the surgery. That is the reason we put the drain there. So that drain comes for some days, then automatically body, like whatever the pathway is disturbed, so it will get closed and the drain will reduce. We remove the drain and discharge the patient. Okay, so but so many lymph nodes are there. Even if you remove all lymph nodes also, but that lymph node is nothing but the lymphoid cells. Your blood has that lymphoid cells. It does not that much effect. So nothing to worry, Nikita. Yeah, role of P53. So it is actually the main reason. So who is the culprit for all cancers? So he's actually the caretaker of all genes, all mutations, whatever the problem is happening has to be taken care and has to be corrected by the P53. So if the problem happens in the P53, so remaining all corrections, gene corrections, everything, nothing will be done. So that will lead to the cancer. But till now, there is no approved drugs against the P53. So future, I'm hoping if something comes, that is very beautiful because it works in all cancers if it comes.
Oh, okay, sir. I think we can conclude the session with that. Hoping.
Okay.
Thank you,
Thank
sir.
you, Krishna.
Yes, sir. Thank you, sir. Thank you for accepting and for the wonderful presentation. We're looking forward, sir. Thank you. Thank you, everyone. Thank you, sir. Yeah.